الرحمن الرحيم. Osteoarthritis or osteoarthrosis, OA, is the most common arthritis, is a major cause of pain and disability in old people, characterized by focal loss of articular cartilage. It is progressively rises with age. Pathophysiology. OA is a complex disorder of both genetic and environmental component factors. Degeneration of articular cartilage is the defining feature of OA, so the site of pathology is in the articular cartilage, while in rheumatoid arthritis, the main pathology is in the synovial membrane. So here, in the articular cartilage, there will be fissuring between bracket fibrillation of the cartilage, leading to the development of deep vertical clefts, leading to decreased cartilage thickness. This is initially focal, mainly targeting the maximum load-bearing part of the joint. Later, large parts of the cartilage surface are damaged. There will be ossification of the joint margin, forming osteophytes. Osteophytes, which are horizontal bony projection. There will be bony enlargement of the failing joint. Later, deformity of that joint and muscle wasting, nearby muscle wasting due to disused muscle wasting. Now the clinical features of osteoarthritis. Clinical feature of osteoarthritis. Osteoarthritis has a characteristic joint distribution. Osteoarthritis targeting mainly the hips, knees, proximal interphalangeal and distal interphalangeal joints of the hands, and first carpometacarpal joint at the base of the thumb, cervical and lumbar spine. The main presenting symptoms are pain and functional restriction. Signs and symptoms of osteoarthritis. Pain. Pain is of insidious onset over months or year. It is of the non-inflammatory type of pain. The early morning stiffness is for a few minutes. Usually it is less than 15 minutes. The pain is related to the motion and movement. It is relieved or decreased by rest. As regarding the signs, there will be restriction of movement. There will be sometimes palpable or audible crepitus, coarse crepitus. There will be bony joint swelling, deformity of that joint. Deformity in the knee is of the varus type. In the knee there will be genovarus. In the muscle wasting, nearby muscle wasting. For example, quadriceps muscle wasting in knee in advanced OI of the knee. Now we shall speak about osteoarthritis in different regions of the body. In the hands. In the hands. In the hands, osteoarthritis of the hands, there will be Haberdin's knots in the distal interphalangeal joints. There will be Boucard's knots in the proximal interphalangeal joints. OI also involve the first carpometacarpal joint, first CMC joint, at the base of the thumb, leading to what is called square hand. The distal phalanx of the finger may be tilted or deviated laterally. Now, knee OI. OI of the knee joints may involve the patellofemoral articulation and the tibiofemoral articulation. The tibiofemoral articulation is the weight-bearing articulation. There will be pain in the tibiofemoral articulation. The medial compartment of the knee is the first compartment to be affected. So there will be a disproportional medial compartment narrowing. This disproportional narrowing will lead to deformity known as genovarus, bowing of the knees. Bowing of the knees, it is called genovarus. Bowing of the knees, this is called genovarus knee deformity from advanced tibiofemoral osteoarthritis and disproportional narrowing of the medial compartment of the knee more than the lateral compartment of the knee. So, in such condition, there will be pain. Pain is on weight bearing, on walking. There will be joint, bony joint swelling. And there might be a Baker popliteal cyst swelling. Baker's cyst swelling in the popliteal fossa. It is called popliteal cyst. Baker or popliteal cyst. And the patellofemoral articulation, OI of the patellofemoral articulation. This presented clinically as pain, especially in getting upstairs and downstairs and in squatting positions. Now, few words on hip OI. OI of the hip joint. OI of the hip joint might affect the superior part or the medial central part of the joint. Hip pain is usually maximal deep in the anterior groin with variable radiation to the buttocks, anterolateral thigh, knee or shin. The hip OI might be associated with trochanteric bursitis, so there might be a localized tenderness on that trochanteric bursa. Here, X-ray of the hip showing the superior and the central OI changes. Osteoarthritis might affect the lumbar spine or the cervical spine, leading to pain and restriction of movement in the cervical and lumbar spine. There might be a neurological pressure effect on the nerve roots, and in advanced cases there might be a spinal canal stenosis. In advanced cases, spinal canal stenosis. Now, investigations. A plain X-ray of the affected part of the affected joint may show the following findings. 1. Narrowing of joint space. 2. Marginal osteophyte, which is a horizontal bony projection. And we have a subchondral sclerosis. And we have a subchondral cyst. Radiological degenerative osteoarthritic changes. Radiological osteoarthritic changes are very common in middle-aged people and over, and most of them might be asymptomatic. So there is a poor correlation between the clinical features and the radiological features in most of the cases. So the patient should be assessed clinically as just we have said, many people with radiological degenerative changes are asymptomatic. So the treatment should be based on the clinical evaluation. Anyhow, management. Management of the osteoarthritis. We have the lifestyle changes. We have for lifestyle changes, reduction of weight in obese people is very beneficial, especially for weight-bearing joints, for the osteoarthritis of the hips, of the knees, and for the lumbar spondylosis. In the spine, in the cervical and in the lumbar spine, the osteoarthritic changes are called spondylosis. They are not called osteoarthritis. They are called spondylosis because they are fibrocartilaginous joints. They are not synovial joints. Physical therapy is very beneficial. Physical therapy is very beneficial. Different heat modalities for the lumbar, for the hips, and for the knee are used. Shortwave, microwave modalities, and the infrared also. The muscle strengthening exercises, the isometric exercises, are very beneficial. For example, in the knee OA, in osteoarthritis of the knee joint, one expects to have a wasting of the quadriceps muscle. Quadriceps is the stabilizing muscle of the knee. It is the extensor mechanism of the knee. So wasting of the quadriceps are treated by strengthening isometric exercise, stabilizing exercise, and avoiding the repetitive trauma, avoiding prolonged walking on that joint, avoiding any repetitive trauma as prolonged walking, as cycling. Cycling is very harmful for the knee joint. Also, for the lumbar spine, extensor exercises which will strengthen the paraspinal muscles are also beneficial. Use of walking stick is also useful for the hip and knee OA. Specialized shoes are also useful if we have leg length discrepancy. The patient having leg length discrepancy, that should be corrected by a specialized shoes elevation. For the pharmacological therapy, in addition to the non-pharmacological measures which we have said, mentioned, one may use the paracetamol, pharmacological therapy. Paracetamol should be tried at first. One may add to paracetamol, one may add non-steroidal anti-inflammatory, but one should be careful in using non-steroidals in hypertensive patients and in patients with gastritis or patients with DU. So oral non-steroidals and oral paracetamol. Paracetamol and non-steroidals orally can be combined. One may use localized ointments, localized gels and ointments, non-steroidal ointments. Now, few words on interarticular steroid injections. Interarticular steroid injections might be used sometimes, but if one uses the interarticular steroid injection, one should be very careful, and this should be done under strict aseptic precautions. Otherwise, one may have septic, one may induce infection, leading to iatrogenic infections, to iatrogenic septic arthritis. This interarticular steroid injection might be used in the first CMC joint, carpometacarpal joint, at the base of the thumb, or in the knee joint. Now, a few words on chondroitin and glucosamine. دعايات الشركات عن glucosamine are very exaggerated. Actually, they have some small benefit. Their benefits are slightly more than placebo therapies. Slightly more than placebo therapy. It is mentioned here that it is not more than 3 to 5% more than placebo therapy. A few words on osteoarthritis in old people. Actually, osteoarthritis is one of the principal causes of pain in old people. The joints with osteoarthritis might develop a calcium phosphate deposition disease. It is called with acute attack. Acute attack due to CPPD, crystal deposition, is called pseudo-gout. Falls reduce muscle strength and pain may increase the falls. Muscle strengthening exercises are very beneficial. Muscle strengthening exercises for the quadriceps, for the knee, and for the paraspinal muscles. Oral paracetamol and topical ointments, non-steroidal ointments, are very safe and important drugs in the old osteoarthritis. Now, the last line of treatment in osteo is the surgical treatment, the total knee replacement, the total hip replacement, and corrective surgery for toes of the feet and other joints. Hand picture with osteoarthritis showing the Haberdine nodes at the distal interphalangeal joints, Buchar's nodes and the proximal interphalangeal joints, and the squaring of the hand, square hand, due to adduction of the thumb due to osteoarthritis of the first CMC joint at the base of the thumb. It is called, leading to adduction of the thumb, this is called square hand. In addition to other findings as wasting of the muscles and gathering of the hands due to wasting of the muscles of the hands. Yes. Picture of the hand showing the what is called nodal osteoarthritis. Haberdine's nodes at the distal interphalangeal, Buchar's in the proximal, and adduction of the thumb due to OA at the base of the thumb at the first carpometacarpal joints. Keep in mind that there is a poor correlation between the radiological findings and the clinical findings, as degenerative changes are very common. Degenerative radiological changes are very common radiological finding in most of the middle-aged people, and but most of them are asymptomatic. X-ray of the advanced OA of the knee showing a typical medial compartment involvement. So there is a disproportional narrowing of the medial compartment of the knee. The medial compartment of the knee, there is a severe narrowing of the joint space in comparison to the lateral compartment. With subchondral sclerosis and osteophyte formation at the joint margin. Osteophyte, horizontal bony projection. Picture of OA of the hand